A very warm welcome and good afternoon to everyone joining us for our Arthrex Ortho Engage Coffee Room series. I would like to begin with some basic information to help us navigate today's session. Firstly, it is my legal obligation to inform all our guests that this session will be recorded and will be available on arthrex.com. In addition, the session will be broadcasted live on social media platforms such as youtube.com. I would like to now take this opportunity to welcome our esteemed faculty, Professor Mohammed Nassif, a specialist foot and ankle surgeon from Cairo, Egypt. Dr. Nassif is not only one of the founding members of the Egyptian Foot and Ankle Society, but also an active member and committee member of prestigious organizations such as ISICOT, CCOT, and AFAS. I'd like to also extend a welcome to our moderator for the session today, Dr. Ursula Zanowicz from Warsaw, Poland, and she's currently working at the FIFA-accredited Medical Institute, Caroline Medical Center. Dr. Ursula gained her experience from countries such as Austria, Brazil, France, as well as the prestigious Harvard Medical School in Boston, Massachusetts. Thank you both for being with us today. Especially in light of our current situation, we thank you for your support and your contribution is highly appreciated. As you can see, this is the fourth session of our Ortho Engage series. Yesterday, we did osteotomy around the knee, where we had over 500 live participants. And in the last 24 hours, we've had over 1,500 views on the Ortho Engage channel on YouTube. So if you missed that session, I encourage you to go and have a look on our Ortho Engage channel. Coming up next week, we have the irreparable cuff on the 27th and ankle arthroscopy 2 on the 29th. I would also like to take this opportunity today to thank all the healthcare professionals from around the globe for your courage, compassion, and dedication during this global crisis. Thank you, and we salute you. Before we move on to the main event, I would like to just cover some housekeeping rules to ensure that the atmosphere is clear and free of any background noise. So please ensure that your microphones are muted at all times. During the Q&A session we'll be having after the first presentation from Prof. Nassif, you can provide us with your questions on orthoengage@gmail.com. Alternatively, if you're joining us on the Microsoft Teams application, you can put your questions directly in the chat box. So once again, thank you all for joining us, and I'd like to now pass on to our first presentation, Prof. Nassif. Thank you. Over to you.
Hello everyone, it's a real pleasure to be with you guys. I'm Nassif, Mohammed Nassif, and in today's webinar I'll try and talk to you a little about ankle arthroscopy, the ABCs of it. For some, this might be a little bit on the boring side. They might already know and are experts in how to do ankle arthroscopy. So for those of you that are experts, I will try and show you a few of the tricks and tips that I have learned over the years. I've been doing these from 1999, so I have like 20 odd years of experience doing these. And for those who are still learning, I'll try and keep this as simple as I can because I hope this would be a sort of a guide for you learning how to do these adequately and efficiently. So these are my disclosures. I do have to bring them up, of course. Obviously, they do not have anything in relation to this particular talk, or at least I hope not. And so I think today the aim should be the description of how to perform a simple ankle arthroscopy. Maybe illustrate some of the technical tips and tricks and how to avoid the potential pitfalls during performing these procedures. And what I think is very important is how to develop a stepwise manner in which to approach the ankle arthroscopically from both the anterior or the posterior sides. So let's start with anterior ankle arthroscopy. Now we all know that the ankle is a very constrained joint. It's formed of the articulation between the distal tibia and the fibula and of course the talus. And if we remember in 1938 there's a very famous saying by Bergman who used to say that the ankle is not suitable for arthroscopy, and possibly this is because of the configuration of the talus and the tibia and how constrained they are in both the sagittal and the coronal sections. Now, it's unlike the knee, whereas in the knee you can make a portal on either side of the patella and possibly you're not going to end up injuring so much. But on the ankle, the subcutaneous layer of the ankle has a lot of important structures. These are namely the saphenous nerve, the superficial peroneal nerve, and of course the schuler nerve. And these can be seen here on the cross-section of the ankle joint. As you can see, you have the great saphenous vein on the medial side and lateral branch of the superficial peroneal nerve on the lateral side. And it's within these structures, these massive neurovascular structures in the center, and these two structures on either side, that you want to create your portals. And we all know that the portals of the ankle, like mainly the workhorses, are the anterolateral and the anteromedial portals. There is the issue, of course, of distraction. When I was starting out, distraction was a big issue, and even some surgeons would not perform ankle arthroscopy except with an invasive external fixator to perform an distraction. Of course, there are less invasive methods, such as the straps, whether it's onto the edge of the bed or with the surgeon's feet. But the whole aim was that this joint is so constrained that we need to stretch it out and be able to perform this ankle arthroscopy. But is that still holding true up until today? Well, this is one of the is a photo that was taken from one of my cases, which was actually, I think, around 2003, and that was the contraction, the setup we used. And because we did not have at that time commercially available kits, I had to go out and try to make one locally made, just for the aim of distracting. At that time, I thought it was very, very important. But I have since learned from then that that is not really necessarily the case. It also is the same with instrumentation. When I was starting out, we were all taught that we need to have these 2.7 short caliber scopes, but it would be almost impossible to do it with a 4.0 scope. But now, actually, I'm more and more using only the 4.0 scope. Actually, maybe for the past 10 years, I haven't even used the 2.7 scope at all. So, as regards positioning, I would rather put the patient on the edge of the table, of the operating table, in a supine position, and perhaps use my belly or stomach as a force to keep it in dorsiflexion, and then relax that and perhaps let it fall from dorsiflexion to plantar flexion, as I might show later on. So this is just a schematic drawing, and excuse the drawing because I'm no Picasso, but this is just a schematic drawing for the ankle with neutral flexion. So the anterior capsule of the joint would be this, and this is very important because we know that the neurovascular structures are quite adherent to this capsule, especially in the middle part. And as most of the procedures would involve shaving, structures would be potentially at risk. Now, if you stretch out the ankle, yes, you would have a lot of space. You would have created an intra-articular space where your scope might go in. But as the capsule stretches, so does the neurovascular structures. It actually might lie more adherent to the capsule than if it were in the normal neutral position. Whereas in dorsiflexion, when the ankle dorsiflexes, you do create a lot of working space anterior to the tibia. You might not create the same amount of space inside over the talar dome, but the neurovascular structures actually stretch out backwards, or anteriorly in this case, and so I think they are a little bit more safer. And this was very nicely depicted by Vega et al. Recently in 2017, showing how much the dorsiflexion method might be more useful. And so this is the method I would defer to when doing an anterior ankle arthroscopy. Maybe I might need traction for certain cases. Yes, one of them would be the osteochondral lesions or the osteochondral lesions of the talus. And this because I might want to gain a perpendicular axis with my mosaicplasty or with my instrumentation to attack that and perhaps create my osteochondral plug and plant it in later on. I might also need that for syndesmosis examination or manipulation or perhaps treatment, and maybe in some fracture cases we might get into that later on in the discussion. So what about those portals? Are they just anywhere? they have a specific area. We know the anterolateral and anteromedial portals, but where exactly would we place them? You can start off, and I did take these photos from the Amsterdam Foot and Ankle platform. A very good friend of mine, Nick van Dijk, I know him now for more than 20 years, and he's actually, I put them up not just because they're great photos, but as a credit and a thank you note to Nick, because I think most of what I have learned in ankle arthroscopy is largely credited to this great man. So if you start off by marking the medial and the lateral malleolus, the tips of both medial and lateral malleolus, in a neutral position, that will be a good part to start when you're marking out your surface marking for the anterior ankle arthroscopy. And then if you move your finger, your thumb possibly better, across on the distal end of the tibia, then you can reach up until the soft spot. It will fall into that soft spot. So we can all find that soft spot very easily. And right next to that soft spot will be the anterior tibial tendon. Then we can put the other thumb up across it and just feel that anterior tibial tendon. That's a good landmark to start. But where exactly still would you put those portals? Now this was a picture from one of my cases. I think it was maybe more than 10 years ago. And at that time I thought they were fine. The portals are okay. This is on the medial side of the tibialis anterior tendon. This is on the lateral side of the superficial peroneal nerve. Well, not a big deal. I'm away from it. And this is the way I was doing my scopes. I think I did have a little bit more of a complications than I have now, and I'll show you why, I hope. So, are these portals actually good? Are they in an adequate location? Well, let's go back to these portal placements. When you have identified your anterior tibial tendon, you want to place your portal on the medial side of that. But how much medial, we'll see in a while. Also on the lateral side, you do want to identify the superficial peroneal nerve, the lateral branch of the peroneal nerve. And we know that you can easily get this by doing the, as they call it, the fourth ray sign, or by inverting and slowly plantar flexing the foot. You would see that robust or little part of the nerve there, and you should mark it out in that position. But mind you, it is absent in almost 25% of people, so you should look for it, but don't worry about it if you don't really see it. But what does that lead us to? It leads us also again to the medial side. So we know that we've marked out the superficial peroneal nerve. Now 2 points that we have to take into consideration when marking these two structures are the anterior tibial nerve, when you look for it in plantar flexion, but as you move progressively to dorsiflexion, the anterior tibial tendon tends to move laterally. So if you're going to mark it as close as you can to the anterior tibial tendon, then you best be safe by marking it during dorsiflexion. That's the most medial you can get. But mind you, if you move a lot plantarly, then your scope is going to perhaps tether against it a bit. So you should take that into consideration. The same applies for the superficial branch of the peroneal nerve. Now, if you mark it in plantar flexion, that's the way you looked for it. But if you move back to dorsiflexion, then the nerve moves a little bit in the subcutaneous tissue laterally. So you might want to place your portals with that into consideration. So I think over the years I've moved from this to this. As we can see now, I would rather on the medial side go more lateral, so as medial as I can to the tibialis anterior tendon, while on the lateral side, rather than doing it on the lateral side of the superficial peroneal nerve, I might want to put it onto the medial side of the superficial peroneal nerve, as long as the tendons of the extensor digitorum allow me. It depends also on your pathology and what you're going to treat, because whereas this might be more or less stationary, this might be mobile. I might want to do, for example, an arthrobrostrum or a repair of the lateral collateral ligaments. In this case, I might want to take my incision just a little bit more laterally to the nerve than as to it being medially. So it largely depends on what I need to do. In addition to the anteromedial and anterolateral incisions or portals, you also have accessories such as the inferior anteromedial and the inferior anterolateral. Now take for example this case of mine. I was preparing for an arthrobrostrum. As you can see, I clearly went lateral to the nerve on the lateral side, whereas I was very, very close to the tibialis anterior on the medial side to gain as much accessibility and viewing as I can onto the lateral side on the opposite side. A very important part of my procedure is the joint inflation. I use this combination. I take 200 milliliters of isotonic saline. I add to it 1 milligrams of adrenaline per milliliter. These are prefabricated capsules, and I break them up and I dissolve them into the 200 millimeters of saline. I take 15 millimeters of these, and I might add 10 millimeters of Marquis. This is both to control the bleeding, of course, naturally because of the adrenaline, but also it's important for me to inflate or insufflate the joint, and I'll show you in a while why. And then we can think about the tourniquet later on. So this is showing just the soft spot once more. So I've marked out my markings, my superficial skin markings, I've marked my portals, and then I want to proceed to insufflate the joint. And I would do that taking the syringe, mind you, because we have taken the 25 almost cc, so I would use a very large needle, as you can see there, maybe almost 20 or 25, and then I would insufflate it into the joint. And as you see, as the joint gets insufflated, it pushes the capsule, the anterior capsule, forwards, and on the lateral side, there would be a bulge on the lateral side, and the foot would progressively dorsiflex because the anterior capsule is getting distended and is pulling that foot upwards. So what have we done till now? We've positioned the patient on the edge of the bed. The foot is freely moving on the edge of the bed. We have done the skin marking. We have also placed our portals and we have marked them out, and then we have done the joint inflation. And then we can think about if we're going to use a tourniquet. I routinely use a tourniquet. I do know some surgeons do not routinely use that, but I personally use a tourniquet all the time. And then I prep and drape. Perhaps the only time I might think of not using a tourniquet would be in a fracture or fracture-related situation where I would be thinking of doing a scope in addition to the fracture. Then we go on to the draping and the preparation. Now, what's also important about the anterior ankle arthroscopy is the technique. You have to just nick the skin, as you can see there. I then use a small mosquito clamp or a separator. I separate the skin. Remember, right lateral to you is the tibialis anterior nerve. You might injure this great saphenous vein on the side. As you can see, I keep the instrument open, and then I put in my obturator, blunt obturator, there. I dorsiflex, as you can see, the ankle joint, and then with a little bit of pressure I would then proceed to pierce the capsule. As you can see, my hand is showing what happens to the talar articular surface when I dorsiflex, so it hides beneath the tibial platform. And then there you can see the pop of the capsule, and I direct it towards the lateral side, almost transversely, as you can see, to the joint, horizontal to the joint, just beneath the neurovascular structures in the capsule, directed to the other side in dorsiflexion. And also what I think is very important is the handling of the scope. So we have penetrated the joint using our grasp, using our wrist, with the ankle in dorsiflexion. But from then on, if you want to handle, and this I also learned from Nick, what you can do when you're handling the scope is using what he likes to call this pistol grip. So your middle finger will be always adjacent to the skin. That way you do not inadvertently pull out the scope. Remember, this is still a 4.0 scope, and there's still not a lot of room to maneuver inside, so you might inadvertently pull the scope out. And also I use my thumb to rotate that light source cable, and then it rotates the camera, and so I can look with ease with just my thumb moving and that middle finger stationary onto the skin. And this is the view you should see immediately first when you start off. The ankle is dorsiflexed, and you're looking across the joint from the medial side to the lateral side, seeing the joint space. If you reduce that dorsiflexion just a little bit, then the talus might start to appear from underneath the tibia, and you can be looking directly across laterally. And that's where you would still normally start your procedure. Now we've created the anteromedial portal, which is the viewing portal. We want to create a working portal from the anterolateral side. So taking the skin markings into consideration, what I would like to do is insert a needle first, and that needle would be seen arthroscopically, as you saw in this slide there. Now, what are we supposed to be seeing arthroscopically? Well, this is the view you should be seeing immediately when you enter, with the anterior inferior tibiofibula, which you can scope in and see. If you scope the lens downwards and clockwise, you will see the lateral malleus. You can then rotate it clockwise to see the anterior gutter and the talus. If you continue rotating counterclockwise, you will then get to see the tibia, the notch of hairy, and the talar dome, the tibial undersurface and the talar dome as you're moving from medial clockwise, then to the deltoid. You see the deep deltoid ligaments and the medial side of the talus. Then you rotate your scope upwards to look at the medial gutter with the medial talar dome and the inner aspect of the medial malleus and tibia. And then if you continue rotating counterclockwise, sorry, that moved a little bit quickly. If you rotate counterclockwise, then you can go back to your original starting position. So this is what you would normally see in an ankle anteriorly when it's viewed with the dorsiflexion method. You cannot see much of the anterior tibia or the lower part, of the tibia or the upper part of the talar dome, except if you do more traction. Now, of course, we're going to discuss this later on in the week, in the ankle arthroscopy 2, the soft tissue pathological conditions that can be treated, but we can divide them into congenital, rheumatic, infectious, degenerative, neuropathic, miscellaneous, and of course the most important would be the traumatic, the impingement syndromes and what have you, the sprains, the fractures, and so forth. There are, of course, other bony pathological conditions, such as the anterior bony tibiotalar impingement, the osteochondral lesions of the ankle, and the ankle osteoarthritis or osteoarthrosis. And of course, you can do advanced arthroscopic procedures anteriorly, like use it with fractures, syndesmotic evaluation, prostrums, deltoid, or ankle arthrodesis. So that more or less covers the anterior arthroscopic procedures. Now we should move on to the posterior ankle arthroscopy. So moving on with the posterior ankle arthroscopy, I think what is very important here is also the relevant anatomy, and I would like to remember our dear friend Paolo. He sadly passed away a few years back, and I think his drawings are still very vivid, and they're still in the mind of every one of us arthroscopists when we do these procedures, because his drawings were very beautiful and his cadaveric dissections were equally wonderful and amazing. It still is a constrained joint from the back, and there are some structures, neurovascular structures, such as the shurals, the posterior tibial neurovascular structures, the FHL tendon is also at risk, of course, for injury. And this dictates more or less the way we should be doing our posterior ankle arthroscopy. One of the most important, of course, anatomical structures at the back, if you're looking at, this is also from Paolo, if you're looking at the back of the ankle, you have a few very important structures now. These are between the tibia and the fibula up there, so this would be 9 and 8 here, are the superficial posterior tibiofibular ligament, and of course the deep tibiofibular, what's known as the transverse ligament. You also have the intermalleolar ligament, which is between both malleoli. Just beneath that, you do have the posterior talofibular ligament, and of course there's the groove for the FHL, which is between the medial and lateral tubercles of the talus, and it is bounded, or it is held in place by the FHL retinaculum. So these are the most important structures at the back of the posterior tibia and talus. Now, what is also very relevant is, and these are nice drawings also from Paolo, is the way these structures look from posterior in different positions of the ankle joint. So this would be in dorsiflexion, this would be in neutral flexion, and this would be in plantar flexion. Now, as you notice, by comparison, in plantar flexion, you can see more of the ankle in the subtalar joint than you normally would in complete dorsiflexion. So we have to keep this in mind when we're thinking about doing the posterior ankle arthroscopy. And I think we also owe a lot to, for this endoscopic approach to the posterior ankle, of course, to Nick Van Dyke. He initially described this procedure in 2000. I was fortunate to be with him at the time. And I would also encourage you to look up the surgical technique, because these drawings are actually taken from that paper there. It was later described again in 2009. So what he uses is also a two-portal technique, which also utilizes the same concept as the anterior ankle arthroscopy, i.e. through mainly two portals. And these two portals are lodged on either side of the Achilles tendon, and you'll mark them out by taking a line parallel to the sole of the foot, just at the lower tip of the lateral malleolus, and your line and your portal should be just above that line and on either side of the Achilles tendon, as we said. So you make them actually simultaneous at the same time on either side of the Achilles tendon. Now, the position, of course, of the patient is in a prone position. You would want to use a hip bump so as to prevent the patient from rolling off the table. You might use a tourniquet. I routinely always use a tourniquet. And originally Nick Van Dyke and others have described using with this triangular soft bump to try and elevate the foot a little bit above. And then it's free to hang, and it's free also for plantar flexion. Remember, that's easier, or dorsiflexion if you need it be. But on the table, I think what I do is a little very slight modification. Of course, I do prophylaxis for DVT, but what I do is I lower down the contralateral limb, the limb that I'm not going to be doing the surgery upon, because this allows me this transverse access onto the foot without the impediment of the other limb or the other foot, because remember, most of these pathologies are going to be treated with me holding the scope almost transversely across the heel. But in this position, the position of rest, this patient is usually in external rotation. So what I do is I rotate the whole operative table a little bit clockwise in this condition, because of it's the right foot, and in this way the limb lies more or less neutrally, like from 12 to 6 o'clock, using the face of the clock right in front of me, and then I can work my way at ease and not having to hold my hand in a certain unnatural, unanatomical position. So proceeding from that, as we said, we have marked out the portals, anterolateral and posterolateral, posteromedial on either side of the Achilles tendon. Now, what is very important in posterior ankle arthroscopy, or endoscopy in this case, even more so than in anterior, is the systematic procedure. You have to follow these exact same sequences to do a safe and adequate posterior ankle scope. So these sequences are as follows. Through the posterolateral portal, you would introduce a mosquito clamp or a separator, and you would go directly in the line towards the first web space. In a plantar flex position, almost 20 degrees of plantar flexion, you would actually hit the bone, which in this case is probably going to be the posterior part of the talus or the subtalar joint, and you would just create a a working space. Remember, this is an endoscopy. There is no space, there is no ankle joint or posterior ankle joint there. You're creating one. And that would be the same. You can exchange that instrument then for your blunt obturator and trocar, but in the same direction towards the first web space with slight 20 degrees of plantar flexion. And then after that, when you have done that, you can then then transfer the probe or exchange it for the arthroscope, and you would still keep your hand in that position. Now, each and every instrument that's going to come through the posteromedial portal is going to follow the same exact sequence of steps. It would be introduced through the portal directly perpendicular to the instrument, in this case the shaft of the scope that you're holding, in the posterolateral portal. It would hit the metal directly perpendicular to it, and then you would move your wrist in a slight upward direction. You would be sliding that instrument, metal against metal probably, down to the tip. So your triangulation would be obtained in that way. And each and every, I cannot stress this enough, each and every instrument that's going to be placed later on from that same portal has to be done in the exact same sequences. Now what that does is it kind of separates all the soft tissue and it moves it out of your view, like as if you're drawing a curtain away from you. At that point, you can withdraw the scope just a few millimeters backwards. So what you'll be doing is you'll be able to see the tip of the instrument you've just placed on your monitor. And these are the systematic procedures you have to follow to perform a safe and adequate posterior ankle endoscopy. As you can see there, your shaver would have been introduced first perpendicular, hit the metal, and then go down, sliding across till you see the tip. Then you withdraw the ankle scope a bit backwards to see that tip that you want. And another tip is that when you are working, you have to look for both joints. You have to see the ankle joint and the subtalar before you decide how to proceed. Of course, if you see the FHL, then you know that you're safe, because anything lateral to that is safe, and anything medial to that is probably going to end up in the neurovascular bundles, and we certainly do not want that. So once again here, the FHL, the talus, the back of the calcaneus, the subtalar joint there. So this would be our working area, all lateral to the FHL. Of course, if you do venture medially, there are a lot of structures, and studies have shown that the posterior tibial nerve is at an average of 6 millimeters, only 6 millimeters away from the FHL. And you can actually see the structures if you become more experienced. In this case, it was a tarsal tunnel syndrome, so I could dissect between them, but I would not advise that except after you feel comfortable, and I would simply not advise it at all anyways, especially for beginners. Now, this is just a scope, just to show the view that you might encounter upon. So in the beginning, I was very fortunate. I stumbled right across the FHL. I moved the big toe. I know that that's the FHL. So any instrument that will be introduced in the same sequence. The burr, the shaver, or whatever will be directed away from the FHL lateral. And as you can see, this is an important tip, is where to keep that angulation of your scope. I'm always looking laterally, always with the scope, so I do not wander into the medial surface. In this case, it was a simple excision of an ostrigonum. We're working lateral to the FHL tendon. As you can see also, I do not remove a lot of the soft tissue, the ligaments of Ranvier and Cuvier, because I believe that adds to the stiffness. In this case, I managed to get out the ostrigonum in one piece, but that doesn't always happen. This is just to show you the anatomical structures you can see from the posterior aspect of the ankle. So after you've done the simple posterior endoscopy, you can treat a lot of various pathologies, either articular or periarticular, such as the posterior ankle or the subtalar joint. You can also treat the periarticulars, the FHL tenosynovitis, tibialis posterior, brachiocalcaneal bursitis. And these are the classical indications or pathologies you can treat. But you can also treat advanced indications, like using the posterior endoscopy for FHL transfers, talar body cysts, posterior talar OCDs, tarsal tunnels, as I showed in a few slides back. Anatomical variations, of course, they are there, and you should keep them in mind of the FHL. You can also want to do, in the same patient, concurrent anterior and posterior ankle arthroscopies if the patient happens to have both pathologies, say an anterior bony osteophyte and a posterior ostrigonium that you want to deal with. And I wrote this up a few years back in the Casta journal. I think it was in 2014. It was a combined arthroscopic management of concurrent anterior and posterior ankle pathologies. Some other authors, they've also described doing that from a single same position. So you have the position set up, for example, in a lazy lateral position, and then you can do both scopes at the same time. But that, for me, was not really very ergonomic. I did not feel comfortable doing both positions in that way. Anyway, I mean, this is all about ankle arthroscopy. I mean, surely there's nothing new anymore. Well, actually not, you know. In an editorial that was described actually a few months ago, just at the end of 2019, they described the ankle arthroscopy as a new wave, as something that is still going to come back again at us. And actually in the same journal, in another editorial, just recently, 2 months ago, this was in February, they talked about the novel needle arthroscopic system, the nanoscope, which I was fortunately very lucky enough to try in its trial phases. So what is this? Is this the future? It's a needle arthroscopy. It's a nanoscope. Now, what is the nanoscope? It's a 2.2 millimeter semi-flexible. That's including the sheath. And you can use this for any varied options you want. You can check it. You can use it on to diagnose entities. And what's nice about it is that it comes with its own dedicated small instruments. So it comes pre-packed, as you can see. You have the syringes there on the side for the insufflation, for the fluid into the irrigation into the joint. And the instruments are very small, and they can be used at the same time. If you have a very small maybe impingement, you want to check a second look on an OCD you've performed, you can use this. So I think it's really neat. It does come with its rolled-in screen. And the problem with the previous versions or other versions of the needle scope was the resolution. I think the nanoscope is giving us now, I think it's a 400 pixel, so it's a really nice instrument to use. The resolution is good. And I think it would be very valuable for office examinations, second looks, tendinostomies. You have a whole load of options you can use this with. So I'm sorry I've taken up so much time, but it was a bit difficult to talk about the whole of the ankle arthroscopy. So in conclusion, I think we should know adequate knowledge of the arthroscopic anatomy. We should train and practice first in cadavers and in labs. And I think there'll always be room for improvement, no matter how good or how many times you've done it. And perhaps we can even look more in the future to more innovation. Thank you, guys.
Thank you, Dr. Nassif. You've kind of stumped me because the question that I had to kick off the session was something that you've just covered. So the question that I had to get us started, guys, was, what are the fundamental tips and tricks that you could give to the audience when starting with ankle arthroscopy? So you've kind of covered these. Is there anything else you can add, or anything from you, Ursula?
I think it was a wonderful presentation. Really, we all have some tips and tricks to do this, but I think just take your time, don't rush, be sure what you see is actually there, and then it's really safe. Just follow the steps.
Okay.
Prof, yes, I think. I think I second, of course, what Ursula said. If I were to break this down, I would say before you start on the first patient, if you've not started an ankle arthroscopy yet, you should do it on a cadaver, and you should get that courage, that feeling of what you're doing. Almost any one of us from a first-year resident can feel the soft spot of the ankle joint. You can inject an intra-articular injection, but that's not all it takes to do the ankle arthroscopy. You need to know what you're going to do and consequently where to place the portals. And another last tip I might add is that it's very essential. We're sometimes in the rush in the OR and we want to get it over and done with. We just mark out quickly. We might even forget the sequence of events. But I think systematic approach to it, you mark the portals, you insufflate the joint, you raise up your tourniquet, then you prep and drape, and then you start your scope. I think if you adhere to these systematic steps, you're more often going to get it right than wrong, and lessen the complications, of course.
Agreed. Thank you. I have one follow-up question for you guys, and this is to both of you. I mean, both of you have an extensive knowledge and background in ankle treatment as well as ankle arthroscopy. How has your approach to ankle arthroscopy changed from starting out to where you are currently today? Ursula, to you first.
I think I have more courage to do more and more things arthroscopically, and I'm pretty sure and positive that with open surgery you cannot see as much as we can like this. So I think this is the only good direction, and I'm looking forward for more instruments because I would like to do more things in the ankle joint, especially as cartilage is concerned. And there are some limitations. Sometimes you have to do medial malleus osteotomy, but still I think it's developing, it's improving. And the point is that with a knee problem, people are looking for advice and looking for consultation. With the ankle problem, not that often. And I think when the knowledge among also the patients will come up, people will start seeking for the help and just not getting used to the pain or whatever they have there.
Agreed. Prof, over to you.
I can't say it any better than what Ursula has said. I think, well, if I'm speaking from out of my own experience, I've learned from a lot of mistakes, obviously. Again, I cannot reiterate enough the systematic stepwise fashion. That has changed. I used to be very enthusiastic, much younger, and I would start off straight away irrespective of what I was going to do. But now I take it more systematic. Regarding the scope and if that has changed, yes. I now am more frequently using it as an adjuvant with fractures, with instabilities that I would rather have done open at the beginning. I'm seeing a lot of more pathologies than I usually would, and hence I think I'm getting less complications than the normal open procedures. We do have, of course, a whole range of improvement, as Ursula said, for instrumentation that would help us do the surgeries better, I think. And this nanoscope is also, I think, going to be utilized in offices around the world, because then, how many of us have had an OCD that looks not so good on the MRI, and you're sure it's incorporated, the patient doesn't have enough, any substantial amount of pain. You can just stick that needle in and look at the cartilage, as Ursula was saying, right in front of you, and make sure that that has been taken up, as opposed to a second look arthroscopy or operation for that patient. So yes, I think there is still room for improvement.
Thank you. That leads me to my last question, and then I'll hand over to you, Ursula, as a moderator, if you have any questions. But my last question is, as we see this ankle arthroscopy indication evolving, like you say, with the nano and with other indications, and the indications are getting more and more adventurous, let's say, how would you advise our listeners or our guys starting out with ankle arthroscopy? Which indications would you suggest starting out with in order to get comfortable, to gain some confidence as an initial step? And which sort of indications would you avoid doing arthroscopically in the beginning phases? So, Ursula?
I think you should try to put a scope every time you do any type of ankle surgery. I got pretty crazy with doing with fracture fixation with the arthroscopic control, and at first when I started that, I was really disappointed with the quality of my fixations and the other things that I was missing. So right now it's a routine for me to put a scope in. And coming back to your question, what procedure to start with, I think anterior impingement is pretty safe, and this is something I would start with and get experience and more courage to do more and more, and to look in all the little places in the ankle joint and subtalar joint as well. All the fusions or the arthrodesis I do right now arthroscopically, and I think it's a huge advantage for the patient because it's minimal invasive, the scarring is not too big, and it's really quick and easy.
Thank you. Prof, over to you.
No, absolutely. I agree with everything Ursula has said. Yeah. No, because it's true. I mean, yes, I would do it first on a cadaver. Then, if I have gained some courage, I would then start off with the anterior anterolateral impingements, the anterior bony impingements. Fusions are also easy. You might be wanting to remove the cartilage, so it's not a big deal if you inadvertently scuff off at the beginning. And there's no shame in taking out the scope and then putting the screws or whatever it is you're going to fuse your ankle with under C-arm or image control. But it's yeah, I second everything Ursula said. I don't really have anything to add there.
Okay, good. Ursula, I'll hand over to you. If you have any questions, you can direct to Prof, and I will check the chat to see if there's any questions coming from that side.
I think we could move forward to this few cases we prepared together and discussed. Okay, there's one question I can see here. I'm going to answer. The question was, Dr. Zdanovic, could you please explain me more about arthroscopy with ankle open reduction internal fixation? Is it dry arthroscopy? Yes, it's dry arthroscopy, and one of the cases is about that, so it's a great question, so we'll go back to that. Okay,
great. We'll go over to you. You're going to start up your cases?
Okay. Just give me a second. Okay, can you see the screen? It's okay?
Yeah, we can see.
Okay.
Just slide presentation mode.
It should be okay. So first case, 17-year-old girl with giving away symptoms of the right ankle joint. On clinical examination, for me, she was unstable as far as ATFL and CFL are concerned. So she had in clinical examination instability. X-rays were normal. And in the ultrasound, surprisingly, it was described as all ligaments are intact. So I got a little confused, and from also the legal point of view, it's pretty tricky. But I talked to the patient and I explained everything. I said clinical examination is one of the most important things. So I'm going to show you how this clinical examination looked like. I cannot forward the slide. Okay, so this is the way I examine ankle joint. This is for the ATFL and the CFL, that just the clear supination. So she was unstable. Of course, you can even more easy see with the examination under anesthesia. So when the patient is already in the OR. So I started with the...
Sorry, Dr. Ursula, if I can just jump in. Prof.
Yeah.
Nassif, are you seeing the screen correctly? I think you muted, Prof.
Yes, Ursula, Dr. Ursula, I don't think we're in
Presentation
in
mode?
slideshow. Yes, in slideshow mode.
Okay, let me try that again.
That looks a little bit better. No.
I'm so sorry for this problem. Let me try that again. And now? Can you see the screen?
That looks better.
But
We're
can
on
you see?
case 1, 17-year-old girl.
Yeah? Okay.
Yep. Thank you.
No problem. Thanks for information. Okay, so this is the clinical examination. Can you see the movie?
Yes, clear now.
Okay, so this is the way I examine ATFL and the CFL, just the clear supination. So I was positive that she was unstable. And this is her anterior ankle arthroscopy. This is the right ankle joint, anterior lateral compartment. So if you are able to actually see the cartilage surface of the fibula, it means that there must be instability. Normally, you do not have such a clear view in here. So what you see, there's a picture on the top left. This is tibia. Fibula, the articular surface of the fibula, talus, and the anterior inferior tibiofibular ligament in here, okay? So then I looked to the lateral compartment. So I thought, okay, this is the ATFL. This is anterior talofibular ligament. So the continuation is there. But if you look closely, this ligament does not attach to the fibula. It attaches to the capsule. And maybe this is why some unexperienced radiologists can describe it as a continuation of or intact even ligament, but you can feel that it is unstable. Yes, because if you look back to this pictorial essay, the one of the best articles I've had about the ankle anatomy, you can see that the ATFL must attach in here to the fibula. So this is a tricky thing to check it out, and this patient is obviously unstable. So like the key message after this case is to trust your clinical examination, to start cooperation with radiologists. They need your feedback, otherwise they will not improve. Maybe stress x-rays are the option. To be honest, I don't use it that much. And the arthroscopic evaluation sometimes can be really tricky. So you have to know exactly what you're looking for, and you have to know the anatomy very well. I don't know, Nassif, do you have any comments?
No, actually, it's very, very nice, and it shows exactly the point of you have to know the normal arthroscopic anatomy, because maybe if someone else, they would have depended, they already are entering into the case, they know the radiologist says there's nothing there, they looked in with the arthroscopy, they didn't not only look at it, they did not probe it. So that's another point, that you have to probe the ligament. And there is this entity now in, I think, the last 5-6 years, this micro instability, which is being used of the superior anterior talofibular part of the anterior talofibular. I think
we discussed it yesterday. Yeah.
Yes. So this is more or less with that. Let's call it a mild form of avulsion, but it's there, and definitely, I think the keynote you said is that because you know the ankle without distraction, you cannot see the inner surface of the fibular articular portion, and you definitely cannot see across onto the syndesmosis, then you know that means there's an laxity. So you are more agitated to look for it. So great job.
Any questions from the audience? I cannot see the chat right now. I would have to go out from the presentation mode.
No, I think, sorry, Dr. Ursula, if you like, you can just jump onto the next case, and Mike, if you're with us, and there's, yes, and I'm also managing. If someone is asking, I'll try and answer quickly and return the question to you.
Thanks. Thank you. Okay, so we move to the second case. Pretty easy case, 18-year-old boy presented with chronic anterior ankle pain. Conservative treatment was not effective. On clinical examination, anterior ankle pain with palpation, the joint was stable. On the x-ray, some osteophytes in the anterior compartment, ultrasound, some synovitis in the anterior compartment. So this is his x-rays. You can see the osteophytes, even though it was a pretty young boy, he was 18. And this is the anterior arthroscopy. So what you can see here is the anterior tibial rim hanging over. So the key thing is when right now I'm moving the foot. Okay, so I was plantar flex and now I'm dorsiflex. So if you look from the front to the ankle joint and you cannot see the joint line, it means there is something covering it. There is something overlapping, and this is as much as you have to cut off with the conflict in the anterior compartment. So to show you, top left, you have at the beginning of the surgery, and in here you have it when I already cut the osteophyte, and we can actually see the joint space looking from the front. So conflict in the anterior compartment is pretty common. With the camera in the ankle joint, one should see the joint line, and this is as far as you should go. The other thing, but it concerns only the non-degenerative joints, is go to the level where you see the attachment of the anterior inferior tibiofibular ligament, because this is where the rim originally was. Some two other tips: always direct the bone cutter towards the bone or down. Especially with the bone cutter, it's a huge instrument comparing to the ankle joint. The suction can be really huge, and you can suck up the arteries and the tendons, extensor tendons that are on the top. So really be careful with that. Sometimes I even give the camera to my assistant, and I have both my hands taking care of the bone cutter, because sometimes it kind of jumps from the bone, and it's pretty dangerous. And I'm not a very huge fan of chisel. I think you have to be careful with it. I know that it seems like it's much quicker, but very often you can cut much more that you would like to. So be careful with that one. Do you have any comments, Nassif?
No, absolutely beautiful job. I think I would reiterate just the 2 points you said. The anterior, like we showed in the normal anatomy, the osteophyte is actually below the capsule. It's actually below the attachment of the capsule to the rim. And this is why, as you so rightly said, you have to be sure that when you're looking from the, in this case, the anteromedial porta, you're looking across tangentially at the other side, which is the lateral in this case. When the ankle is in dorsiflexion, you should see the ankle joint, and right across, if you just scope in a little, you should see the anterior inferior tibiofibular. So if you don't see that, anything that is protruding beyond that tangential line is an osteophyte. And as you also rightly said, when you're using the bone cutter, it always has to be from the top down, so you're saving the capsule, the reflection. And as you said also, you use the suction intermittently. So you take it on, remove a little bit of the bone debris, then you stop and you shave on. And you can use it with this cutting block technique, which I like to use from the knee joint, where you know that, for example, this shaver is a 4.0. So I start from one point, I shave just the width or the girth of the shaver, and then I move tangentially along because I know I'm not removing more than that 4.0 millimeters. That's all. I like the part about be careful with the chisel. I use that in a few cases earlier on. First of all, it's much easier with the bone cutter or these really nice instruments, shaper instruments. The chisel has the option of when you're hitting on it to slide off, and that might be a little bit dangerous. So yes, you should be very careful. So we said yes, starting out you can try with anterior bony impingement, but I would not start out with a chisel if these are my first cases. Yes.
Okay, so let's move to the third case. A 32-year-old woman, she had a car accident. She was diagnosed with trimalleolar fracture and she underwent open reduction internal fixation. She came to me for the consultation 4 weeks after the surgery to continue treatment in my clinic because she was operated in the other city when she was on holidays. These are her x-rays. You could say many little things about the way it was fixed, but it's not like totally wrong. I mean, it's acceptable. At least it was acceptable for me when I saw it. So what would be the next step? I have this this rule that whenever I take over the patient who was not operated by me, I always do the CT scan to actually see the quality of the fixation and everything. To have, even from the legal point of view, you have a proof in which condition you took over the patient. So I did the CT scan, and I must say I was really surprised because there was a huge loose body in the posterior compartment. Plus, there were a bunch of little loose bodies. Plus, as you remember the x-ray, she had the syndesmosis fixed with a screw, but in between the tibia and the fibula, there was another loose body. So I had to reoperate on her, and this is what I took off from the posterior compartment. She had a posterior ankle arthroscopy. And in this case, it was a couple of years back. This case led me to thinking that one of the major risk factors of early osteoarthritis in the ankle joint is previous fracture, even though those fractures seems to be well operated. So I thought, okay, so it's just not possible. Why would the arthrosis start so quickly? So I thought maybe we don't know everything about this fracture. And then I was discussing with myself with the standard approach to the fibula, to the medial malleus, to the posterior malleus, you cannot see what's in the joint. And so I would say, in my opinion, X-ray underestimates the extent of pathologies in malleolar fractures. We are actually right now publishing a paper with Dr. Szymański about that. And in our case series, it was almost 100 patients that we checked, 20 to 25% of missing pathologies in the joint. So in my opinion, pre-op CT scan is a must, but if you don't have it, the arthroscopic control is a must, and it doesn't take much time. It doesn't give you much bigger cost. You can see the syndesmosis, you can see the and shave off the loose bodies, you can see the quality of your fixation if it's intra-articular fracture. You can actually see this anterior inferior tibiofibular ligament. So you can see the Chapeau fracture, for example, which is really hard to see with the standard X-ray, unless you are lucky. So this arthroscope with treating the fractures is a must. And because I'm also the knee surgeon, all the intra-articular knee fractures are treated with arthroscopic control. So I thought it would be not logical not to follow the same pattern in the ankle joint. Do you have anything to comment, Nassif?
I'll first ask you a question because of the from the participants. They are interested in this naturally because it's trauma also. Someone is asking you. I think it's Eisenbow, Stefan. He's asking you: are you doing CTs in all malleolar fracture cases?
B and 3 malleolar fractures, yes.
Exactly,
CT in all the cases, preoperatively. And the paper we are going to publish, it's pretty simple. We took retrospectively all our patients with B and 3 malleolar fractures. All of them, they had 3 positions X-rays, AP lateral and Mortis view, both ankles, so you can compare. So your detectability is much higher. And we compared it blinded with the CT scan that is in my clinic always performed. And it was evaluated by a resident who is usually in the emergency department, by me and by radiologists, and still up to 20% of missing pathologies. Mostly it was a Tilo or Chapeau fracture, loose bodies, and syndesmotic injuries. So if you cannot see up to 1/5 of the pathologies, in my opinion, it's a must to do the CT scan. On many courses, people are saying, I do the CT scan if I have doubts. The problem is that you won't have doubts because it will look okay on the X-ray. It would look simple. And with your standard approach, you cannot see the whole joint. So if you do not want to do a CT scan, or you can't, or you don't have this possibility in your hospital, put an arthroscope in. It will, make it easier to see things and to treat them. This is what I think.
And just to reiterate your point there, Zvernik, I think in 2018, he showed us that, as you rightly said, arthrosis, post-traumatic arthrosis occurs in 20 to 30% of cases with adequately reduced fractures, and this explains these large number of cases. So yes, I'll just follow up on that. You said that you, because the patient was being transferred from or was under another medical care, you did the CT as routine. Are you brave enough, like we've started becoming now, to do CTs for your traumatic cases? And I reserve them for certain cases. I'll discuss these now with you and with the audience. So do you do routine CT for post-traumatic cases that you fixed?
You know that I do, because we discussed this, and this is a really scary moment to look post-operatively about that. Not maybe bimalleolar fractures, but the Tilo intra-articular fractures. I do the post-op CT scan. I talk to the patient before the surgery that I'm going to do this because I want to check if it's okay. Because probably the next question would be, what do you do if it doesn't look good? I reoperate those patients. I think the ankle joint is it's unforgiving. Absolutely. And in the knee joint, you need at least 10 years to have arthrosis. In the ankle joint, it can be a few months. So it's really important, the quality and the syndesmosis. First of all, it's a key to prevent the early osteoarthritis in the ankle joint.
Yes. So what we do is that any supination, external rotation, any trimalleolar fracture that is going to be fixed, we do that because this rotational component, as you rightly said, might affect the Tilo Chapeau or the posterior loose body. There are a lot of questions here about how do you do the arthroscopy in a fracture or in a suspected fracture case. What are your sequence? And are you afraid, this is from Khaled Sisi, Are you afraid about compartment syndrome using an arthroscopy in an ankle fracture? So I'll leave you, Ursula, to comment on these 2 points first.
Okay. If it's possible, I try to do dry arthroscopy, and I start with arthroscopy. So the fracture is there. I didn't start the ORIF yet. I put the arthroscope. I flash the blood that is there. It can take up to a couple of minutes, and then I look.
No pressure.
No pump. No
yes,
pump.
No
pump
vital.
at all.
No pump.
Sometimes exactly. A little bit gravity. It's pretty tricky, and you have to get used to this. I mean, it's not as well visible as the cases I showed you before, but still it's visible. And then when I fix it, if it's intra-articular fracture, I put the scope in, and sometimes really on the C-arm, it looks beautifully. And if you put the scope in and you see the articular surface of the distal tibia, it's just not that beautiful anymore. And I think it's hard for the surgeon to see that, but this is the only way to improve.
Exactly, yes. So to round that off for Dimiral Patel and Khalid Assisi, the sequence of events: you do the scope first, you inflate the joint, you remove the debris, you do not use an arthroscopy pump or any sort of pump.
No.
You might want to use gravity,
sometimes some gravity, but I'm really careful not to cause the compartment syndrome, of course.
Yes, yes. And as maybe all I will add before to what Ursula has so beautifully said is I do a compression stocking and I leave it in place, an elastic bandaging on the foot. I am going to operate foot, ankle, and tibia up until the popliteal space that I'm going to operate, knowing that I might do a scope to check it first. So I do the portals and the incision through that compression, so it also saves me a little bit of this extravasation and compartment syndrome. That's all I would add.
Excellent. Yeah. But on the other hand, anybody who operates the knee joint and who uses the arthroscope when fixing the tibial fractures, we don't have as many compartment syndromes as people would be afraid of.
Yes.
And in the ankle joint, it's even easier because the gravity goes away from the cuff, not up.
Exactly.
You know, from the knee joint it goes down, from the ankle joint it goes down. So I don't think the risk is big. Of course, you have to think about this and take some steps to avoid it, but really it's not a big deal.
Yes, exactly. And Kari is asking, you also use the 4mm scope when you're going to be doing this in a fracture case, and he's asked, and another person was asking about the nanoscope. Would it be a potential role for fracture cases?
I think so, yes. I don't have that much. I've tried the nanoscope. I liked it, but I don't have that much of experience with this one. I use the regular scope, the 4mm, the knee scope, and usually it's okay. It's not a big deal.
Yes. So Joshua, just to elaborate on that point about the nanoscope, I think it would be great if you're going to use it for a person who's walking into your office post a fracture and still has some pain. X-rays look okay. You're still not going to get that CT. You might want to use it. Remember, it does come in a disposable kit, and you can use it as you can in situ there. That would be a good indication for it. But to use it intraoperatively instead of the normal scope, yes, I know this is an ArthroX lecture, but you would be adding extra cost in that particular situation. But it would be beautiful to be using it in the office later on. We have to be honest about this point there. So I would probably be using the same scope that I would be planning on using there. Okay. And last question from Kari about this point before we move on to the last case, Ursula, if you don't mind. How would you avoid the skin incisions? So you plan the skin incision for the arthroscopy. I guess he's asking in relation to a fracture case, or would you only use the anteromedial portal in that particular scenario of a fracture which you want to look at arthroscopically?
I mean, you can have an anterior medial portal to have a quick look and to decide what you do. Sometimes you see the tilo fracture or chapeau fracture, and you have to extend your incision from the fibula as well. I don't think it's a big deal because these are the arthroscopic incisions, so it's like 5 millimeters long, and even if it's close to the main approach to the fibula, I haven't noticed any problems with that.
Yes, exactly. And lastly, I will answer Khalid Sisi. He was asking, he said that the ankle is not forgiving and the skin, I think he means complications are more serious. Actually, Khalid, on the contrary, I think, and Ursula would agree, or I don't know, she has another opinion. I think the ankle is very forgiving in the context of scope with compartment syndrome, if that's what you're relating to. Because as she pointed out, firstly, you're going to open up later on to fix that fracture. And so some of this extravasation will also be let out. Number two is the skin incisions, as you said, they're just nicks onto the skin. So even if they're very close to your incision, it's not such a big deal. And at the end, you can actually extend the incision and later put the scope just through that same incision to check, through the open incision to check. Because I would be more worried about the patient walking into my clinic after 4 months, maybe 6 months, maybe a year, with an unexplained, at that time I would say it's unexplained, arthrosis. And you know that these are usually traumas that are happening to younger generations. I've seen 20, 25, 18-year-olds who have had severe arthritis. They've been walking on their ankle. People are telling them, your x-rays look fine. And they end up with maybe an ankle fusion. Ursula?
With those arthroscopies accompanying the fracture fixation, I haven't seen problems. I think the more risky is when you dissect the skin with a really thin subcutaneous layer of the fat, and this is the key problem. With a skinny person with a really thin subcutaneous layer, you have to be careful with dissection, like horizontal dissection. With the incision, you do the incision for the fibula, you just go directly to the bone almost. There's nothing in between. And arthroscopic incisions, there's no reason, so it's more risky than doing normal arthroscopy.
Yes, and this is the last point I will say here before we go into your last case, Ursula, because it factors into this conversation, this subcutaneous point you pointed to. I have had so much less complications because at the beginning, I used to be, even in a normal arthroscopy, just a standard arthroscopy, no fracture, I'm not going to open up, with this overzealous shading to see more, especially if you come nearer to the portals. So I have stopped doing that, and the incisions are faring well. They are not getting infected. There is no fistula. I haven't seen one in ages now, well, in at least 15 years. But I've seen them more when people are more zealous in shaving off the subcutaneous, because remember, this ankle is almost adjacent to the bone. So that little amount of subcutaneous tissue you have beneath the skin to the capsule, you should save as much as you can. And that goes whether you're doing a normal arthroscopy or you're doing an arthroscopy with a fracture. Let's move on to your last case, if you don't mind, Ursula. Thank you, Dr.
Yes,
Ursula.
it's the last one, so don't worry, guys. 56-year-old woman. She had a posterior ankle arthroscopy due to the chronic pain. She had her ostrigonum removed. And after that first surgery, she presented with major pain and paralysis of flexor muscles. When I saw her, she was already after 5 revisions. And so this is the problem is the left leg. For some reason, and don't ask me why, all the next revisions were getting up and more up. I cannot explain it. But the thing is that she had an injury to the tibialis posterior nerve with the posterior ankle arthroscopy. At this level, it innervates the flexor muscles. So this is how her left foot looks like. And I wanted to show you how she walks. She had a constant pain, left foot. Look, there is like domination of the extensors, and she cannot fully flex the flexors. So this is the way she's walking. She's in pain. I didn't treat her finally. She decided to go somewhere else. But this is the first case I saw, not read about, that type of complication. So for the summary for this case, be careful and slow until you are sure where you are with the posterior ankle arthroscopy. I've seen many people and many surgeons confusing subtalar joint with the ankle joint, because when you enter from the posterior, you see nothing, and then you see something, and it looks like a joint. There is a smooth cartilage. So if you mistaken this for the ankle joint, but you are in the subtalar joint goes obliquely. So you start to direct all your instruments in the wrong way, and you go exactly for the tibialis posterior nerve. I think there's no shame in doing X-ray control. So if you are lost, if you are not sure, double check with X-ray. You'll know when your instruments are. And this complication may actually happen. So let's do everything we can so it doesn't happen to you. Anything from your side, Nassif?
No, excellent. Yes, this it's nice to see that. Hopefully, it doesn't happen to anyone, but it's nice to see that some complications can happen. Even this was a patient that was going in for a normal posterior ankle arthroscopy, and look at how it ended up. And I can promise you, this is not going to be treated completely well, or she's not going to recover 100% from this. So yes, we have to be very, very careful. Like you said, when you are doing the posterior ankle arthroscopy, you should not do any shaving before you know where your two joints are. So if you see a joint line you think is the ankle, you have to look for the subtalar. If you see a joint line you think is the subtalar, you have to look for the ankle. This is one point. If you're fortunate enough to find the FHL, you move the big toe. The musculocutaneous junction is just at the ankle joint. There is it never is below that. It never is below that. So if you see only the tendon, then you're probably at a lower level. And like you said, you should always keep lateral to that structure and never go medial to it. But to do that, you have to first find the FHL or know which joint you're opposite to. So beautiful cases, Dr. Ursula. Thank you very much. There was a question from one of our participants, Dr. Yazan. He was asking, how do you assess your syndesmotic reduction arthroscopically? I'll let you answer that first, please.
I think it's very subjective, and it's too subjective to actually give you a tip. I'm scared about doing over compression and not to do enough. Usually when you look to the literature, it seems like if we think about this, we usually have the tendency to overcompress the syndesmosis. But the good thing is that once you remove the screw, the nature will forgive you for that. I don't put as much force as I used to. I'm trying to put a scope in and to look for the normal anatomy. If it doesn't look normal, if it's too wide, too big, or I can see too much, which is not normal for ankle arthroscopy, I start to think twice if it's okay or not.
Okay, yes, excellent question. Excellent. I would just add to that two points. I have been doing now more and more. I drape and prepare the opposite foot, especially if I'm treating a syndesmotic only or a syndesmotic with a fracture. So my resident or my fellow he preps and drapes the other foot. And I use X-ray control. I am very, very, because we do not have in our country intraoperative CT. I'm this is my black area that I'm very cautious when I'm doing it. So I check the other in the normal, in lateral and in AP mortise views. And I use the tibiofibular overlap because that is the most significant we have found, and the one that is not changing with however the distance of the X-ray beam. This has been proven in laboratory tests, so I use that. And I use on the AP, on the lateral view, the posterior fibular dissector, which is the line across the posterior fibula and the talus. And I compare this to the side I am operating upon, and I try to be within 2 millimeters. So when I come to tighten the screw or the tightrope, I use now more and more tightropes because of that particular scenario. I tighten, I take a look, and then I go back. I tighten, I take a look, and go back, so that I can gauge it. But I think Yazan's question was related to using the arthroscopy intra-articular. Yes, when it's inside the joint.
For me, I would say it this way. For me, it's not the only thing I look at. So I take the X-ray. To be honest, I look more for the space in between the medial talus and the medial malleus. I think the widening of this area, it's a key to see if you fix the syndesmosis well or not. I put the scope in, but there are no rules described what you should look for. So I'm trying to look for the normal anatomy, as I said. So I have a picture in my mind whenever I do the arthroscopy. I see this area, so I'm trying to see if it looks okay or not. But I don't think this is the answer you were looking for. I'm so sorry.
Yes, the group from Christy Giovanni in Harvard, they have created small probes that they put in, and they have calibrated these probes from 1 millimeter, 2 millimeters, 3 millimeters, 4 millimeters. And they say that these probes, I have never used them, but I know Chris personally, and I've seen his paper. I think it was just last year. And they use these probes to kind of calibrate if you can introduce that probe into the junction, into the syndesmosis, and they think that is not adequately. But I think there's still a lot of research that should go into that particular area.
One more thing that arthroscope can help you with. Sometimes I've noticed that there's a bunch of soft tissues in between the talus and the medial malleus. Sometimes it's a deep layer of the deltoid ligament. Sometimes this is just some fibrotic tissue or whatever, synovial tissue, and it can prevent you from proper reduction. So always put a scope there and see if there's enough space so I can do the reduction with the syndesmotic screw or tightrope or whatever.
Absolutely, and that's another reason for maybe doing the scope with the fracture. So I think, I'm not sure, Mike, I think we've covered most of the questions from the group here. You want to, Mike, are you with it?
Yeah, okay. I'm with you. I think we have, Dr. Nassif. Thanks so much. And at this point, I'd just like to thank you both once again for your time. Dr. Ursula, I can see you still in the clinic and working hard, so thank you very much for making the time to support us. And Prof. Nassif, always a pleasure. Thank you so much. We'd like to just invite everyone for the remaining sessions that are coming up next week. And yeah, thank you very much, everyone, and we'll sign off from here. Have a good afternoon.
Thank you.
Thank you,
guys. Take care.
Bye. Bye, Nassif.
Bye.